Welcome to the 40th Annual Legislative Conference. We look forward to having an engaging and informative session on health disparities and health reform legislation and how it impacts us. I'd like to first thank our sponsors, Pitney Bowes and DaVita, for supporting this session. Now we will have John Love of Pitney Bowes, followed by John Schaeffler of DaVita, provide some opening remarks.
Good afternoon, everyone. I'm John Love, president of Pitney Bowes Government Solutions, and it's our great pleasure that I stand here today on behalf of the more than 33,000 Pitney Bowes worldwide supporters of the 2010 Congressional Black Caucus Foundation Emerging Leaders Series Forum. I'd like to take the time to thank the Congressional Black Caucus Foundation and its membership for the over 40 years of service given to you, to this movement, in creating opportunities for the economic, political, and social advancement of communities of color. Like the CBCF, we at Pitney Bowes believe in the importance of educating communities on the pressing issues impacting them and their families. Healthcare, in particular, is an issue that spans demographics and impacts us in a number of ways. With the recent passing of healthcare reform, we must all now be committed to understanding how this law will impact each of us. More than ever before, we will need to rely heavily on you, our youth, to become more involved at the forefront of policies and be part of the decision-making process that will have a direct impact on your generation and generations to come. We at Pitney Bowes believe that an increased focus on literacy and education through supportive programming and mentoring will help address societal issues that span the spectrum. This not only speaks volumes to our continued commitment in supporting the Congressional Black Caucus Foundation as they look forward to advance the social economic circumstances that has impacted urban communities, but it also underscores Pitney Bowes' strong support and commitment in making a difference in the lives of the people from the communities in which we serve and do business. At Pitney Bowes, we value the 10-year partnership we've had with the Congressional Black Caucus Foundation, and as a civic group whose mission parallels Pitney Bowes' corporate mission to advance communities, and we look forward to our continued partnership over the next 10 years. Thank you for your support and your time this afternoon.
Good afternoon. I'm going to be really brief, but I want to tell you really quickly about this great company that I work for. It's called DaVita. We're a dialysis company, so when your kidneys fail, you have end-stage renal disease, DaVita is there to do the function that your kidneys can't do. We take care of over 100,000 patients a year. We have 1,600 centers around the country, and we do it through the care given by 32,000 employees that we call teammates. And my favorite teammate is right here, Cam Smith, and she's actively involved in the CBCF. DaVita has been actively involved in the CBCF. It's a great partnership, and it's an important partnership for us because African Americans have a 4 times greater chance of getting kidney disease and having their kidneys shut down than other parts of the population. Kidney disease is caused by high blood pressure, diabetes, diet. So it's very important that we work with the CBCF to help educate people because at the end of the day, I don't want to see any of you folks in our facilities. And so a big part of what we do is screening and education. So I'm going to ask you all a favor, and that is at some point today, if you can get over to booth 609, we will test you, and we'll see and screen you and give you a sense of what your susceptibility is to having kidney disease. And if it turns out, unfortunately, that there's something there, we can work with you to educate you to prevent the onset of end-stage renal disease. It's something that we take very seriously at DaVita. By show of hands, I know I talked to one person who's from Ohio. How many of you are relatively local in the DC area or close? Good, because there's another thing that you can do, and that is for free, you can join DaVita at RFK Stadium on October 16th, and you can participate in a walk and run. And it's a 3.1-mile walk or run. We'll all lose a little bit of weight, we'll lose some calories, and we'll help our kidneys. So Cam can share with you any information. There'll be other information at the booth when you get your screening. But come and do yourself a favor, do your kidneys a favor, work with DaVita, and we're looking forward to this week, and thank CBCF. Thanks.
Thank you, Mr. Love and Mr. Scheffler, for providing your remarks. The moderator, Dr. Levis, is a professor in health policy at the Bloomberg School of Public Health at Johns Hopkins University and the director of the Hopkins Center for Health Disparities and Solutions. He's a recipient of various prestigious awards in the field of public health and serves on the numerous boards for public health institutions. Let's welcome Dr. Thomas Levis to the podium.
Thank you and good afternoon. We're going to get right into it because I think we have an exciting panel today. We have several leaders, important leaders in health policy who are going to talk about healthcare reform and what that new bill means to our community and the role that emerging leaders can play in making sure that that bill is implemented in a way that it benefits the people that it was designed to benefit. So we're going to move right into it. I'm going to do a brief introduction of each of the panel members, and after that introduction, those introductions, each member will speak for about 2 or 3 minutes. Hopefully we can keep that as brief as possible, and then we'll throw it open to a dialogue. And what we want to do is have kind of a conversation about this bill that we've been hearing so much about over the last year or so. And there's so much misinformation out there about the bill. We want to try to see if we can clear some of that up and make sure that we all leave here with a good understanding of what health care reform is about, why it was needed, and how it needs to be implemented. And vigilance, and I'll make one last comment about that, is that vigilance is necessary. Because many people think sometimes that once a bill is passed into law, that the battle's over. But in reality, that's when the battle really begins, because the implementation of that bill and the full funding of that bill, what happens in appropriations, is really what determines how that bill will impact and whether it will have the desired outcomes. So it's important that we continue to be vigilant in our sort of monitoring of this bill, even though it's not on the front page of the newspapers, what's happening behind closed doors, and that's really very important. So we have many distinguished panelists today. The first is Denise Brooks-Williams, who is president and CEO of Battle Creek Health System in Michigan. Ms. Brooks-Williams received her bachelor's in psychology and master's degree at the University of Michigan before starting her career as a management fellow at Mercy Hospital in Detroit. She currently serves as president of the National Association of Health Services Executives, which is the largest minority health professional organization in the United States, and she was recently named one of the top 25 minority executives in healthcare by Modern Healthcare magazine. And she's also a former classmate of mine at the University of Michigan, so I'll point that out. So go blue for all you Michiganers. Daniel Dawes manages the Federal Affairs and Grassroots Network at Premier Healthcare Alliance. He worked closely with over 200 national organizations and coalitions to ensure that health disparities were addressed in the healthcare reform legislation. Daniel was a senior legislative and federal affairs officer at the American Psychological Association and worked for the Senate Health, Education, Labor, and Pensions Committee under Senator Kennedy. He also worked for for the Congressional Black Caucus Health Brain Trust under the direction of Congresswoman Donna Christensen. He holds the JD degree from the University of Nebraska School of Law. Next, we have Jamal Simmons, who's a principal at the Rabin Group in Washington, D.C. He emerged from CNN's 2008 presidential campaign coverage as a new, fresh voice in political punditry. I like that line, political punditry. He got his start in politics traveling with then-candidate Bill Clinton in his 1992 presidential campaign. Mr. Simmons served as a political aide in the Clinton administration and in Congress before heading to Nashville as Deputy Communications Director for Al Gore in 2000. He also served as traveling press secretary for Senator Bob Graham and General Wesley Clark's presidential campaigns in 2004. And he was an early supporter of Barack Obama in 2008 and served as an advisor to the Democratic National Committee during the Obama-Biden campaign. Raised in Detroit, another Michigander, Mr. Simmons is a graduate of Morehouse College and Harvard University. Please welcome Mr. Simmons. Reverend Robert Henry Hughes is youth pastor at Providence Missionary Baptist Church in Atlanta. In 2009, Reverend Hughes founded the Generator Development Group in Atlanta, Georgia, to grow the practice of spiritual, sustainable, ethical, moral leadership in the urban communities. Reverend Hughes also serves as chairman of the boards of the Atlanta Interfaith Broadcasters. He is an executive committee board member with Concerned Black Clergy of Metropolitan Atlanta and the Faith Alliance of Metropolitan Atlanta. He currently is pursuing a doctorate in ministry degree in urban ministry at Wesley Theological Seminary in Washington, D.C. He is a 2005 Master of Divinity degree graduate of the Morehouse School of Religion and the Interdenominational Theological Center in Atlanta, and earned his Bachelor's of Science in Communication from Ohio University in Athens, Ohio. Welcome, Reverend Hughes. And finally, Sharon Tate is Public Health Analyst with the Office of Program Analysis and Coordination at the Substance Abuse Mental Health Services Administration. She is Coordinator for Partners for Recovery in the division and provides guidance in the administration and planning of the center's initiatives with a special emphasis on criminal justice, alcohol issues, workforce development, minority health. In addition to her responsibilities as coordinator for Partners for Recovery, she serves as a project officer for the Historically Black Colleges and Universities Centers of Excellence, which establishes substance abuse curricula at the 105 institutions across the country and provides recruitment opportunities for minority students to enter the substance abuse field. Ms. Tate is a graduate of the North Carolina State University. Welcome, Ms. Tate. So, each panelist has prepared a brief opening statement, and I'd like to give them an opportunity to do that now before we begin with the questions. So let's begin with Denise Brooks-Williams.
Okay. Can you hear me? You can? Okay. All right. I think if I was teasing with some people in the audience, I was like, this is the third time you get to hear me. So I'm going to make sure I don't repeat myself. But when you think about the politics of health and the reform bill and how it applies to youth, as Dr. Levy said, the perspective that I add to the panel is that of a healthcare delivery system. So I'm the president and CEO of a hospital. And so what I'd like to open with as we begin our dialogue is if you look at, I brought some statistics about representation from a workforce diversity perspective, which is addressed in the reform bill, and it's something that'll be critical as we look at cultural competence and how we work together to ensure that there's access and cultural competency. 6.5% of the 2009 medical school graduates were persons of color, African Americans specifically. While we represent 13% in the population, we would suggest that's an underserved number. 5.4%, excuse me, is nursing. If you look at healthcare administrators, so those would be people that lead health departments, hospitals, health clinics, so where you actually receive the care, less than 2% of them are African American. So as you look at the reform bill and you look at the opportunities that we need to ensure are created for people like me, and I have to be clear, I'm speaking on behalf of NASI, the National Association of Health Services Executives today, not my health system, which is a 48 hospital health system, $7 billion corporation, and I became in 2009 our first African American CEO. I think I open with that to say, as we look at the reform bill, and I'm in a youthful audience, what I want you to consider and think about is the impact the delivery system will need to have from people like you, from people like me, ensuring that when people come through the doors, their care is delivered in a culturally competent, relevant way so that they get the health outcomes and health improvement that we desire for them to have as a result of the access that the bill affords them.
Yeah.
Thought our originally
That's
had
why
7
she's
minutes.
CEO.
That's right. Yeah. So just want to say good afternoon to everyone and to thank Dr. Levice for that warm introduction and say that I'm extremely pleased and happy to be here today to talk on an issue that's near and dear to my heart, and that's the issue of the politics of health equity and health reform. And I'll start out by saying that, as we all know, the ranks of the uninsured and unemployed continue to rise, and yet we have so many people, so many lawmakers railing against the bill, trying to repeal it, trying to defund many of the provisions in there. And this at a time, especially for African Americans who are suffering the highest unemployment rate at about 15.6% right now, and as a result cannot access employer-sponsored health care. So that's a big, big issue right now. And as a matter of fact, last evening, I got breaking news about the ranks of the uninsured swelling now from 47 million last year to about 51 million people this year. And that was pretty frightening, I think. Last year we were quoting, I said 47 million folks, and we were saying that about 83,000 racial and ethnic minorities die each year as a result of health disparities. And that we spend over $60 billion in direct health care expenditures as a result of that. In our conversations last year, what we did was to assemble a group of about 250 organizations representing a host of diverse communities. We have the racial and ethnic minority communities represented. We had businesses, hospitals, pharmaceutical companies. We had children's groups, women's groups, LGBT individuals, and people with disabilities, really coming together to flesh out some talking points, some principles, and then ultimately legislative language that we could share with the key committees in the House and Senate and with the Obama administration. And so I'm just going to quickly go through those steps and how we achieved what we did. I'll also just quickly say that when we're talking about healthcare reform, a lot of folks just consider the Patient Protection and Affordable Care Act, PPACA, which is HR 3590, but there is another piece of legislation, the reconciliation bill, that complements that and collectively make up what we call health reform. So oftentimes I get folks saying to me, oh, but I thought such and such was in the bill. And I have to remind them, no, have you looked at the reconciliation bill? Because during that part of the negotiations, there were many amendments that were offered to strip out some of the provisions that we had fought for and had secured ultimately. So some of the things that I want to point out that this new health reform law is going to do is it's going to expand health insurance coverage for almost 8 million African Americans in our country, or 19.5% of the uninsured and underinsured population. It's going to transform the delivery of care from treating sickness to preventing illness and promoting wellness. You're going to see this transformation of our delivery system from sick care to health care, from what we call rewarding volume to rewarding value. So you're going to see an increase in quality. And as a matter of fact, many of your providers are going to have about 2% of their reimbursement tied to the increase in quality services that they provide. So those are things that are coming through the pike. Then it's going to strengthen protections for the approximately 25% of African Americans who have a pre-existing condition. And again, I know many of you have heard about the non-discrimination provisions in health reform. There was an attempt in the House to really strengthen that, expand the scope so it would protect gender identity and sexual orientation. That obviously never made it in, but we still view that non-discrimination language as very expansive. And we feel that it really aligns well with the data collection provisions that we secured in that bill. And we can go into the politics of that. That was an extremely controversial piece. And there were times when we had to fight even our own supporters on the Hill and in the administration to keep that language in there because it was a cost burden for the bill. So that is another piece That was absolutely critical. Then there's also a requirement for diversity, increasing cultural and linguistic competence in the bills and the workforce, and then prioritizing the disparities research as well, health disparities research. And then lastly, there are numerous grant opportunities in the bill that look at reducing disparities. And if you're part of a community-based organization or you engage in research, there are many, many opportunities for you to apply for these grants so you can develop culturally competent programs and figure out ways in which to improve the health of your communities. Now, so how did we get here? We talked about building this coalition of 250 organizations. We worked closely with the House and Senate and with the administration, and our tagline became, health reform should be reform for all, not reform for some. And as you know, health and healthcare disparities is a critical matter, but it's oftentimes very underrated, treated as a secondary issue, and that was the case in health reform. We had to fight in the Senate especially because they never understood what we're talking about when we say health disparities. They never got the notion of health equity. And even though we went to members who we knew had a large American Indian population in their states, they still didn't get it. So that was one hurdle, trying to increase the education level there. And then for the longest while, we were making a moral argument about, this is going to save lives. It's going to increase the quality of life for millions of racial and ethnic minorities in our country. But that argument fell when, if you might remember, during that time now, it became a cost issue. In Congress, they were all about cost, cost, cost. What are the costs of disparities in this country? How are these provisions going to reduce disparities and decrease the cost? And I have to say this was a very challenging research project. We were only able to find 2 pieces of research, one for Colorado, one for California, that really addressed the whole issue of the cost of disparities. But that didn't fly for senators from other states. They really didn't care. And so thankfully, and I'm going to give kudos to Dr. Levis for his groundbreaking report that came out last September, when I was looking for these figures, Dr. Smedley had contacted me and said, you know what, you don't say anything to anybody yet, but we're coming out with that very number that you need to build the case for including disparities in the health reform legislation. And so because of that, I'm very pleased to say that they took that seriously. But then after that, you might have heard we switched from now comprehensive health reform to health insurance reform. And at first we said, oh, this is great, you're vilifying the insurance companies, nobody likes the insurance companies, right? Well, it hurt us because with the focus now on health insurance coverage, the prevention and wellness provisions, the quality provisions, the workforce provisions were sort of put on the back burner. And we sort of had this feeling that, many in the administration, many in Congress were going to take this approach of, well, you know what? We'd love to include those in, but we just can't right now. There's not that political will to get it through. So we pushed back. There was at one point a newspaper article. We had actually spoken to some senior officials in the administration, and they said, Daniel, the data collection might be at risk. We might have to cut out some provisions that you guys secured, but just know that for the most part, we're going to try to keep everything in. And we said, oh my gosh, the data collection provisions? I said, of all the provisions in health reform, this was the #1 provision that the whole entire group could really agree on. And if we don't have the data collection, or like a robust data collection and reporting system, we can't track the disparities. And then how in the world can we even make the case for including, research grants and others for the elimination of disparities? So that was one phase of it. And then, I guess just to quickly end here, after we got over that hurdle, then we also had to fight the U.S. Commission on Civil Rights, who at that time had many leftover appointees from the Bush administration, fighting the diversity pieces and fighting the cultural and linguistic requirements in the bill, saying that this was a violation of the Constitution, that this language violated the Supreme Court precedent in 2003 on affirmative action. And again, we said, my goodness, could there be another attack? But we were able to fight them back, and thankfully many of those provisions are still in there, but I anticipate that many of these attacks that occurred during the reform will come up again as we move on with implementation. So I'll end here and entertain questions afterwards.
Thank you. Yes, Reverend Hughes.
Thank you. Good afternoon. Good afternoon. It's definitely a privilege to be here with such esteemed panelists and with you here in the audience as well. Many times when I talk in public or share in a private conversation, I'm informed that, Rob, you're speaking to the choir. And as many times it's true that I am speaking to the choir as a minister, but the important part is that these are the people who are faithful. These are the people who are engaged, people like yourselves. These are the people that get it. These are the people that act on it. These are the people that live it. These are the people that make the policy happen in the communities where people actually need the help. And that's the voice that I bring to this conversation, is to talk about how the policies that are created, how they are lived out, how do they affect people in the homes and in the neighborhoods. And I've also learned in my own experience that the road in creating community, the space that we live in, the space that we occupy, is long, rough, and rugged. It's tough space that we all are striving every day to move forward into. And many times along this journey, as we move forward, it is lonely and it is discouraging as we work trying to meet these needs day in and day out, working with families and individuals. We go through the emotional highs and we go through the lows that victory brings, as well as the setbacks, part of the negotiation process. It's tough dealing with the ebb and flow of incremental progress. But yet, as we move forward and we can share in healthy words and we can encourage each other, and that's what I hope to do today, and also to challenge you and challenge myself as I learn and I listen as well. But this challenge in this word is important because it keeps us at the table. It keeps us doing the work that we do. It keeps us believing in people. It keeps us going. It keeps us doing. It keeps us advocating. It keeps us working. It keeps the process going forward. It keeps us working towards creating systems of fairness, being able to create justice, equity in our public health, as well as many other common concerns that we do address through the local church and the faith community. Story about my faith tradition. There was a story about a man who had been sick and had sat by a community pool for approximately 38 years. And he sat there waiting to be healed, and then one day a gentleman showed up who was in his early 30s, and many might call him an emerging leader at the time. And he stopped and he asked him a question. And he asked the sick man, he said, "Do you want to be made well? Do you want to be made whole?" And that's not unlike many of our communities. Many of our communities that CBC constituencies live in for the past 40 years, seeking to find remedies to our common ills. These issues that we're going to talk about today of public health, of health disparities, dealing with childhood obesity. A very issue that's dear to my heart is the bone marrow donor base. I understand that there's 20,000, I believe, donors that are included, and only 7% are African Americans. And someone, again, that's close to me is in need of a transplant, and so I advocate on that end. But as we think about the community engagement that this emerging leader took a part in, he reached out and he helped, and that's the same thing that we're asked to do, to reach out to our neighbors and our friends in the way of public health and offering the question about making them aware and then also walking in their own wholeness. As we continue on as emerging leaders, specifically within the faith community, there's the connection that we have with the broader community, and I think there needs to be a connection and further dialogue between all of our communities. A lot of times, people may not think that there is a connection between faith and health, or it may even merit a discussion, but I believe that by what it is that we do individually as well as collectively, that we need to have all voices involved, and we need to raise the level of awareness again to our brothers and our neighbors and everyone who is impacted by this particular type of policy. Also in our faith traditions, many of the things that we do in the way of celebrations and observances are based around food and diet, I know in the Jewish community, they observe the Shabbat dinner. And our Islamic friends, during the season of Ramadan, when they end their fast through the day, they do the iftar dinner. And then in my community, the Christian community, we participate in communion as a way of observance. But as we think about how food is used in our faith cultures and constituencies, we can talk about those things that does impact things that the sponsors indicated earlier about kidney issues and high blood pressure and diabetes and those types of things. But I also want to bring another point up about why it's important for people on this panel and those who are here, part of this discussion, you in the seats. It's important to engage the faith community because the faith community is changing in itself in the way in which we organize and shift. Many congregations are either large, some people are involved in large congregations or mega churches, some are involved in traditional settings, but I'm seeing a lot more of small, local, home-based churches develop, congregations, not just within the Christian community, but also conversation that just happens in intimate settings over coffee, those types of things, to be able to put that relationship that's built on trust, to be able to influence our neighbors again and our friends and our family. So with that, one of the things that I would want us to consider as we move forward in this discussion is that in order to really help people in the way of health care, we have the responsibility, and I challenge all of us, we actually have to reach out and touch people. We actually have to reach ourselves, we have to extend ourselves, we have to extend our hands to be able to offer the touch to the people. We have to go amongst the people. We have to live amongst the people. We have to hear what they're saying. And in crafting public policies that deal with health, I believe this is a healthy way in which we get to the wholeness that we're all working and striving for. There is a scholar by the name of O'Berry Hendricks, and he simply says that we must treat the people and their needs as holy. And I would like to end with a quote by author Peter Block. And he penned a book that was entitled Community, and it also was called The Structure of Belonging. And he states that for at the most operational and practical level, after all the thinking about policy, strategy, mission, and milestones, it gets down to this: how are we going to be when we gather together? And that's the question that I raise. How are we going to be when we gather together? How are we, as we leave this space, going to be when we gather together? I would like for us to commit to living together, to listening together, to serving together, being able to act together, and being able to love together. If we're doing this, we'll be able to transform the communities and the individuals that make a part of that. And for me, that's what the whole component of this health policy is about, so people can live whole and healthy lives. Being able to transform our communities, being able to renew our communities, and being able to restore our communities. God bless.
Okay, thank you.
So I'm going to be the downer after that great, that great talk. Thank you all for having me, and thanks to the CBC and LaToya Jones, who I don't think I see LaToya, but for asking me to be a part of this. So I think you all know, anybody who's been reading the newspaper or listening to the radio or the internet knows that this is going to be a tough year for people who are interested in taking care of people who are progressives. I think this is my phone going off, which is not fun. Turn that off. This is going to be a tough year. Democrats are going to lose seats in the House. Democrats are going to lose seats in the Senate. A big reason for that, it's going to be partially the way that the health care debate took place over the course of the first 2 years. I do think that what happened in Delaware the other day with the Tea Party candidate winning that race is probably going to keep the Republicans from being able to win control of the Senate. But in the House, I think the Republicans will get close. I don't think that they'll win the House, because I think we've got some pretty good candidates, and we've got some pretty good, we got good money and some issues that will be helpful, but it's going to be close. and they don't have to lose it. But what's going to happen that we have to be concerned about is whoever is in control of Congress next year, we know who the president will still be, that policy does count. And the policies that governments put in place do count. I like to look at poverty as an example of what really, in the broad sweep of American history, has been a success story over the last 40 years, but it hasn't always been a success story. If you look at the trend rates in poverty, you know, this week we found out that the poverty rate's gone up to 14.3%. But according to the National Poverty Center, again at the University of Michigan, which should be giving us money for all this promo we're doing here, in the late 1950s, the poverty rate for all Americans was 22.4%. That went down steadily throughout the 1960s, reaching a low of 11.1%. I'll remind you that Democrats were in charge in the 1960s. That was 11.1 by 1973. Over the next decade, the poverty rate fluctuated between 11.1 and 12.6, but it began to rise again in 1980. By 1983, it had gotten up to 15.2%, and for the next 10 years, the poverty rate remained above 12.8, Reagan and Bush. By 1993, it had increased even to 15.1%. But then that rate declined for the remainder of the decade to 11.3. By into 2000, poverty rate had gone down to 11.3. That was Bill Clinton. And those were the years that Democrats were able to make decisions about how we allocated the resources and benefits that occurred in this country. After 2000, surprise, surprise, the poverty rate started going back up. And so now we even, you know, so by 2004, it had gotten to 12.7%, and we look at what's happened after the recession. So policy does count. And the good news is, again, when we talk about policy, one bright spot when we talk about poverty this week is that even though the numbers of poverty have gone up, as the president mentioned this week when he talked about this, the number of American children without health care has stayed the same. And that's because of CHIP, the Child Health Insurance Program. So S-CHIP has kept even poor children with health care. This is going to be a tough year because that key signature accomplishment of the president in this last government has caused so much trouble. After 18 months, the president was able to pass health care that will expand coverage to about 95% of Americans. The problem is that voters weren't really that interested in expanding care to more Americans. What voters were interested in was the cost of health care. And if you think about who voters are, you can understand why that might be the case. Voters are typically over 30. Voters are typically employed, and people who are employed typically have access to health care. So for them, expanding health care wasn't the same, didn't have the same imperative. And you know, it's also true, and since the recession, everyone else who's lost their job has been more concerned about getting a job than they have been about getting health care. They'll handle health care. If you can get me a job, I'll take care of health care on my own. Even among African Americans, you look at the issues that are the most important. According to a recent poll I just saw and survey I just saw, African Americans are more concerned right now with the quality of the schools for their children. They're more concerned right now with the economy and being able to get a good job. They're more concerned about rising crime rates in their community. And then they're concerned about the health care costs. So you see that even among our community, health care is important, but it's one of these issues that, well, you know, if they're shooting people down the street, I'm a little more concerned about that right now than I am about the fact that I might get sick in a year. Or if I can't afford to put food on the table, I'm a little concerned about that right now than I am about whether or not, you know, something that my neighbor next door has access to health care. And so what you see today is, according to USA Today, in a poll they did at the beginning of the month, the public is opposed to the Democratic health care plan 56 to 39%. It's a big number. So Democrats go into this election season also with key provisions of the plan that we spent 18 months passing. Key provisions of that plan are just now starting to go into effect. Insurance companies, as of this year, starting I think around September 23rd, insurance companies will not be able to deny coverage to children based upon pre-existing conditions. They won't be able to rescind coverage based on a technical mistake in the contract. No more lifetime limits on coverage. Young adults can stay on their parents' insurance until 26. So these are all good things that will happen. But for members of Congress who are running this year, they don't really have a lot of time to talk about that. So things will improve for most people because of this bill, and the president will have great things to run on in 2012. But for Democrats this year, it's going to be a little bit tougher. So what's going to happen over the next 6 weeks as we go into the election? Republicans are going to use health care as a weapon, and Democrats are going to do everything they can to avoid the topic and to talk about something else. So it's going to be a little tough time for us for the next couple of months. And I think as the bill begins to kick in and there are experts here about more of the provisions and things that will happen and how it will work, I think things will start to get better to talk about. But there also is an effort to make sure that we implement the health care bill the right way. A friend of mine likes to say, how many people here, I think some people here are old enough to remember this, some people may not be, remember the TV show, The Greatest American Hero? A friend of mine likes to say that the health care bill is like the greatest American hero. We got the suit, but we didn't get the instructions. So we're going to spend some time sort of groping around, learning how to fly, learning how to fight people, learning how to get the health care bill working before we really get it all done. They've been doing a good job at it so far, but that's going to be a true test of this over the next couple of years is how we implement it. So I hate to be Debbie Downer here, but it's going to be a little bit of a tough year. I don't think that it's going to be the catastrophe that everybody's predicting on television. But that's also only going to happen if people who care about the country get up and show up on election days going into November.
Good afternoon, everyone. I'm very pleased to be here today and just wanted to thank the CBC for allowing me to be on this illustrious panel. We've heard a lot this afternoon about the different policies that will affect us with health care reform, and I'm here as a public servant. I work for the federal government with the U.S. Department of Health and Human Services, specifically the Substance Abuse and Mental Health Services Administration. And what I'd like to say about that is I'm proud to be a part of this panel because that means that the federal government is at the table. And we have an opportunity to sit and dialogue with you, sit and dialogue with others that are concerned about what is going to happen to African Americans and the health care reform legislation. One piece that I would like to say is that you cannot be healthy in your body if you are not healthy in your mind. And we have forgotten about one key area that we deal with at the Substance Abuse and Mental Health Services Administration, and that's behavioral health care in general. We have issues with substance abuse that are not being addressed as clearly as they need to be in this health care reform legislation, and also mental health services as well. It was left out of the legislation altogether from the beginning. And SAMHSA specifically, the agency that I work for, did not get 1 red cent of health care reform money. So what is that saying for the field? What is that saying for our needs and our families' needs as it relates to health care, as it relates to treatment services for any substance abuse issues that we may have, and any mental health needs? One of the specific audiences that I'm here to talk about today are the historically black colleges and universities. One of the initiatives that I work with under my area, which is the Partners for Recovery Initiative, which tries to promote the behavioral health workforce and improve the numbers of African Americans that are getting into the behavioral health workforce, is also social equity, trying to make sure that we are accessing the treatment needs that we have, trying to make sure that we are accessing the other services that we need. So 2 of the areas that we focus on would be the Historically Black College and University Center for Excellence, which is housed at Morehouse School of Medicine. I know we've mentioned a little bit about Morehouse School of Medicine, but how many out there have attended HBCUs? Anybody attended an HBCU? Well, that's great. I have an opportunity each year to work with all 105 HBCUs, and this year created a new partnership thanks to our relationship with Penn Gooden Associates and Westover Consultants and Aetna to work with 105 Voices of History. And this 105 voices will serve as ambassadors, one from each institution, to talk about healthcare and talk about healthcare reform. We're trying to bring the issues of substance abuse and mental health issues to the forefront. Those students that we met with, even just yesterday, were talking about the fact that they're smoking marijuana. And these are the elite students that were brought here by their presidents from their HBCUs that are here to talk about issues related to roommates that may be passing out with substance abuse issues, parents that don't have health care because they are trying to get jobs, as Jamal was saying. That's a big concern. So your health is on the back burner. But what about those that are also incarcerated? We're talking about the needs for the changes with healthcare reform as it relates to the people that we see every day, but a lot of the services that we are getting in our community, unfortunately, are coming at the hands of being incarcerated. So we're trying to see what we can do policy-wise that will help our people to get services both on the inside and on the outside. So we're trying to use the platform with the HBCUs to have an opportunity to discuss what policies they can affect not only with themselves, what changes do they need to make personally that can improve their use of substances, if they're using substances, how to stop that, if they're drinking underage, how to be able to stop that, if they have a parent or grandparent that is a guardian of theirs, what type of services can we get with these healthcare reform changes? What can we do in the communities? Most of the historically black colleges and universities, unfortunately, are in downtrodden communities. So what type of partnerships can these ambassadors provide to the community so that we can actually make some improvements, educating people about the healthcare reform changes, educating people about getting screened to determine your level of issues. A lot of the times we don't feel we have issues. If you're drinking 3 or 4 drinks a day, some people are functioning just fine going to work. But let's really start to take a look at some of these issues. Students are stressed out. They were telling us yesterday how difficult it is to worry about what's going on with mom and dad at home, trying to graduate, trying to find a job when we're hearing the statistics that Jamal is giving us about the unemployment rates. And so this is a time where people are using and abusing substances. So I'm here today from SAMHSA and as a part of Partners for Recovery just to create a dialogue opportunity. One of the things that I wanted to share about our administrator, Pam Hyde, is that she has 4 fundamental beliefs, and that is that mental illness and substance abuse are part of overall health. And we need to look at that, because if we try to separate that and put that to the side, it's not going to get the attention that it needs as it relates to healthcare reform. We need to look at mental issues and substance abuse issues the same way we do obesity. I think someone mentioned that a little earlier. We talked about kidneys and our kidney health. Unfortunately, we're number 1 at the top of substance abuse issues as well. So we have to bring those issues to the forefront. The second belief at SAMHSA is that mental illness and substance abuse can be prevented. So there are programs that we have at CSAT. We have about 207 grant programs that we could pull out and talk about how African Americans are affected. One of those programs is the Minority AIDS Program, a Minority AIDS Initiative. People, especially as it relates to students, I was talking to a professor from one of the HBCUs today that was saying that over 40% of the students on their campus were affected by HIV. 40%. And it's a small college in a small town in a small state. And so she said those numbers were just too ridiculous to even talk about. But the school itself doesn't want to even acknowledge that they have HIV issues on their campus. But a lot of that is also due to use of substances, people making poor decisions with sexual partners, people making poor decisions as it relates to intravenous drug use. And so this is an opportunity for us to see that. One of the other programs that I wanted to talk about was the Youthful Offender Reentry Program. That's another program that we have where about 40% of that program focuses on the African American population. So we're talking about a little bit of hope here, giving an opportunity for young offenders coming out of institutions to be able to re-enter their communities with skills and training that they need to be able to get the care and the jobs and the education that they need. We're talking about being able to improve the numbers that Jamal was talking about with employment. Well, if some of you may not know that if you have a record and you come out of prison and you're trying to go back and actually get an education, you can't get any federal funding to go to school. These are some of the policies that are offshoots of what's going on with healthcare reform that we need to really look at as well. But one of the programs that I did want to mention that we have at the Center for Substance Abuse Treatment are treatment drug courts. Treatment drug courts is a big effort that's doing very well across the country. It's a great diversion program. It's a great alternative to incarceration. But according to our records with the National Household Survey, only about 17% of African Americans are involved in this initiative. So where are we going? We're going to prison. We're not getting the opportunities that we need to get the treatment for the substance abuse and mental health issues that we have on the street as our counterparts may be. We are having to get our services on the inside. And so I will close just by saying that we recognize at SAMHSA that September is Recovery Month. And this is a month where we can really look at the administration's goals of reducing demand and promoting the message that recovery is possible. And so we wanted to get that message out as we're talking about healthcare reform so that people won't look at this as a stigmatizing criminalization opportunity, but also an uplifting opportunity for people to get the health and treatment that they need. Thank you.
Thank you. So before we throw this open to the audience, I have a few questions I'd like to ask. Some about sort of the looking back on the politics of getting healthcare reform passed, and others about healthcare reform going forward and the politics of that and how we monitor the implementation of this big bill. So first I'd like to start with a sort of an observation that I had from summer of 2009. While the politics of getting this bill through Congress was happening and was on the front page of the newspapers. So there was a provision in the bill, in that early draft of the bill, that came out of current Medicare regulations that related to physicians being reimbursed for talking about end-of-life, counseling patients about end-of-life issues. So opponents of healthcare reform responded to that by saying this was the government and that was going to be making decisions about who would get access to care, we were going to ration care, who was going to get that care, and who wasn't going to get that care. And they came up with, they used, I teach health policy, and one of the things that we talk about is messaging and how you frame issues. And I thought they brilliantly framed their issue as pulling the plug on grandma. It was a work of art. I mean, I was just impressed. It was evil genius, but it was genius, right? The response was, no, we're not going to pull. No, well, actually, there wasn't a response from the proponents, except to pull the provision out of the bill, right? Then what I heard from the opponents was that they were going to ration care. The government was going to decide who's going to get that care. They kept saying, pull the plug on grandma. Even after that provision had been pulled out of the draft, they continued to use that. And the response was, no, we're going to fight for the public option. Now, pull the plug on grandma was genius. The public option, I thought, what would be the opposite of genius? Talk about framing. What does that mean? Public option. So they have an option to provide care for me or not provide health care? That's what they're going to do. And what does that mean? Public? Well, public assistance? I mean, it's very complicated and confusing. So I'd like to just get your reaction to the framing and messaging battle that occurred. My observation about sort of the way that the proponents and opponents sort of tried to message around moving the bill forward or stopping it from moving forward. And any thoughts you have on that? And I guess I'll throw this one to Daniel and Jamal, because you two, these are the areas where you guys work in. what was going on there with the messaging and sort of, from my perspective at least, bad messaging? Daniel, how about you first?
Well, and that's a really good question. I'm here, as you were asking the question, I'm here thinking in my head about how we were framing messages too. And I think what happened there and what's still happening is that they were the loudest voice in the room still. And I think for us, folks really didn't hit back with the facts like they should. I heard Jamal mention earlier about getting the suit, but not really getting the instructions. And I think that for the most part, we did maybe a poor job in educating our own members in our associations and in our communities. And I'd like to say that Dr. Innocent, who's in the room here, she came with a brilliant idea about framing the message for the community and looking at the provisions that will have the greatest impact on African Americans. It's a compendium that will be forthcoming in the next several weeks, and it really has charts in there to help guide us, to help folks really understand their rights, the programs that will benefit them under the law. So I think for the most part that was a poor messaging. I know in relation to that, when we talk about comparative effectiveness research too, I mean, I was just stunned at how folks were able to twist and turn it and make it seem like this was, and demonize it and make it seem like it was going to be something that would prevent folks from receiving care, and that when they're doing clinical trials, if it's not evidence-based for a certain group, if a certain drug was seen to do better in a certain group, that the providers are then going to be restricted and can't prescribe a drug that they think might be good for their own patient. So there was all that going around. I think for CER, folks have done a pretty good job in pushing back there, but I agree with you. I don't really understand what was happening there. I think for me, I just got in that whirlwind myself.
Yeah. So?
You know, I think there was a broader issue going on during that whole debate. The Democrats thought that when you win an election, you go into government, you try to get something done. The Republicans thought that you don't let anybody do anything and you just play politics. I think there was a, Democrats were having a policy discussion, Republicans were having a political discussion. Right. And so when you have a policy discussion, what happens is not every Democrat has the same perspective because people come from different parts of the country. They represent rural areas, small businesses, urban areas, African Americans, Latinos. You know, it's a big, diverse tent. So everybody's trying to argue out their policy issues to get to the right answer, make the compromises necessary. The other side, instead of arguing their perspective, business or, you know, let's deal with what's happening with our constituencies, they decided it was in their longer term political interest to just say no to everything. So in that debate, you had a cacophony of voices on the do something about healthcare side, and you had one voice on the no to healthcare side. So it's a lot easier to get that message across, and frankly, the Democrats didn't ever come up with a big, broad, overarching message that made the case. Why? Partially because I think we had this majority that existed in Congress that everyone thought, well, if you've got the majority of the House and you've got a supermajority in the Senate or near a supermajority in the Senate, you ought to be able to do this. What are you talking about? What are you arguing about? So in some ways, that supermajority problem made, I think, Democrats a little bit lazy in the political work of pushing this bill and getting people to understand what was in it for them.
Yeah, yeah. I think it really just points out the importance of messaging and framing. And another question I had, and I'll ask this one of Denise, it relates to the healthcare workforce and capacity of the system, and whether the system has the capacity to expand primary care in the way that the bill and the law envisions, and whether or not there's the capacity to do the increased screening and preventive work that the law is proposing.
And I would say, can you hear me? I can't hear me, so I apologize. I would definitely say that no, the workforce, and I'm going to answer it in two ways, I guess, the relevance to our conversation today. there is not enough, just by sheer numbers, and what I shared, I gave it specifically in African American statistics, but clearly if you just looked at healthcare workers in general, there is a shortage. And so the bill does suggest that for primary care purposes, there would be, I think, a significant expansion in the community health system network, so what we kind of call federally qualified health centers. So there's 1,200 of those now, and it suggests that we double that number. You clearly don't have the primary care physicians to cover that. If you look at primary care right now, it is absolutely the stepchild, for lack of a better term, in the paradigm of medical professions, because we've been a system that's rewarded procedures and rewarded complexity. And I only say rewarded because that's where the financial incentives have been, so nothing negative about that care. So no, don't have the primary care pipeline. And I continue to throw the caution in there if you aren't pushing for the implementation of the workforce diversity, and I think as Daniel said, that was something that people continue to try to ensure stayed in the legislation, because the miscues, the messaging, the delivery of information around explaining to someone that unmanaged hypertension leads to high rates of end-stage renal failure. So not just you have high blood pressure, take this pill and you're 25, that if at 25 you have that comorbidity with poor eating, poor diet, having the predisposition because you're African American, by 55, it's almost a given because you've had your body, on a medication that in and of itself is also working to damage your kidneys. So you need to have a workforce that is diverse so that it can address the issues, because I think ultimately if you don't want it to just end up being health insurance reform and it's really health care reform, you've got to continue to figure out how you're going to improve the quality and get the outcomes that you want. So. Yeah. No to the simple question of is there enough capacity in the current system. From a screening perspective, I think that I heard actually just as recently as this morning some strategic thoughts around the other, and I didn't do like Daniel, I didn't tick off my whole list of every area because I tried to do the brief overview. But the idea around the improvement in community-based and prevention certainly suggests that you might have the funding to be creative about the outreach and the prevention screening. So hopefully that pipeline will be increased. But as we sit today, I think we all have to realize that there is a huge gap. We have to shift the whole model of the healthcare system to meet the intent. And so even when Daniel kind of suggested the excitement that we have because everything got in that everybody wanted to get in, now you're figuring out how to go from where you are today, not lose grounds, not treat anybody unsafely, not ignore the fact that the orthopedic surgeon still wants to earn X, Y, or Z at the same time that you're trying to create the primary care pipeline and they want to earn X, Y, and Z. The confusion that we're going to have, in addition to trying to grow the resources, is going to continue to be a challenge.
Shannon, you have any thoughts about that, especially from the standpoint of behavioral health and substance abuse?
Sure. I'd have to agree with Ms. Brooks-Williams as far as not having the capacity to handle the changes that would come as it relates to healthcare reform from a workforce perspective. There's not enough workers in this field to handle what the needs of the minorities are right now, especially African Americans. I was looking at some numbers today as it relates to that, and we kind of put all minorities together just because it would create a larger group. And so we came up with about 30% of minorities in this study, and saying that we are accounted for about 30% of the population in the United States. But out of all the professions that relate to behavioral health, only about 24% are psychiatrists, and that's out of all minorities. Out of the psychologists, only 5.3%. 14% are social workers, 20% are counselors, 8.5% are marriage and family therapists, 4.9 school psychologists, and 9.8 psychiatric nurses. So if we're looking at at those numbers for all minorities as being the professionals in that field, I would say we have a lot of training to do, that we need to do a lot on our end with the historically black colleges and universities, trying to make sure that they are prepared and understand the importance of going into the behavioral health field, and making sure that they're trained to do so.
So we're going to throw this open to the audience. So we have a microphone. So if anyone has any questions, please raise your hand. We'll bring the microphone to you. But while we do that, I'd like to ask Reverend Hughes a question about community. There's a lot in the law that creates opportunities for community-based organizations to get involved in a variety of things. Any thoughts about that and how your organization is going to respond to those opportunities, and any advice, I guess, for the emerging leaders about what they could do?
Definitely, absolutely. As Shannon was just sharing about the work that she does with the HBCU system, a fair, I don't know the number of the 105, but a fair number of them emerged out of the faith community. Came out of the African Methodist Episcopal Church, Baptist Church. Several had their origins connected with people of faith. And as these conversations happen in the community, again, these conversations happen around tables where people have trusting relationships. And they come to their faith leaders when they have an issue. The gentleman spoke with earlier today, Mr. Clark from New Jersey, was speaking about a panel earlier where he said that they were discussing the issue of prostate cancer. And the way that the issue came about was one of the persons just approached their pastor and began to share with them that they were having an issue with prostate cancer. And lo and behold, the pastor himself was dealing with the issue. And so from a community standpoint, congregations are institutionally set up to be able to carry out the conversation. What would be helpful is to have a more informed dialogue, to be able to connect with the experts that are part of this panel and that are part of this conversation today, to be able to give specific details from an advocacy standpoint, understanding the provisions of the bill. When people hear the messaging, as we've been talking about, across media, they interpret it one way and they think that something's going to happen, and then when it doesn't go that way, they disengage from the entire political process. And I think that healthy leadership in the community, as well as through the faith community, can connect those dots to keep people engaged long term. And that way, they can understand more about how things go, even once it's signed into a law and it's shared through messaging, to what you shared earlier about appropriations and how it actually comes into the local community. And so the organization that I have, Generator Development Group, one aspect that we're working on, particularly with young people, are focusing on the careers that are available. And so, as Shannon mentioned, the lack of certain professionals, these conversations happen in youth group. Well, what do you want to be when you grow up, and those types of things. And to know that those professions need people, we can begin to bring that awareness to the young people that we interact with every day, inside of schools, neighborhoods, wherever we are.
Okay, thank you. We've got a question here from the audience.
Hi, my name is Dr. Elaine Arterberry. I'm a radiation oncologist. I do cancer therapy in the Detroit area. And I'm really impressed by the thoughtfulness about these issues, particularly in the environment that I work in. We do see a lot of the issues regarding health disparities because of the high number of African Americans, certainly in my profession, getting cancer care. But I recently got an MPH at University of Michigan, or actually a Master's in Health Services Administration, okay? And we probably had PowerPoint after PowerPoint about health disparities in that, because a lot of the people there do a lot of research in that regard. And I think there's a lot of misconceptions about what health disparities mean, and how a lot of people feel it's all socioeconomic based. And that's partly true, like in cancer, it depends sort of the cancer. But a lot of the disparities are, and I'm going to use orthopedics and cardiology for the two best examples, okay? African American women get hip replacements at a rate that's 30% less than white women. And it's independent of insurance, socioeconomic, age, et cetera. And when they've done studies on this, they feel, white physicians, orthopedic surgeons for the most part, feel that African American women are more difficult to deal with, less compliant, not going to follow instructions. And so what happens is the patients simply don't get the procedure. The same is true in cardiology, and I'm going to use pacemakers as the example. right? And Denise is going to know about this because she works in a big place. So black women get pacemaker placements. When you have a cardiac event, first thing that happens is the electrophysiologist rolls over with a $20,000 pacemaker and puts it in your chest, okay? That's what's supposed to happen. In African American women, this happens 20% less than it does in white women, and the reasons are the same. And it's somewhat true with the men, but it's really bad for the women. And again, it's a perception issue. And what I'm not hearing from the panel or from the policy discussions is how you're going to do policy that addresses this issue. These are procedures that hospitals make buku money on. The hospital I'm at, the orthopedic surgeon is treated like a demigod. So this isn't a money thing, okay? This is about blink. This is about that instantaneous response patients, doctors have about seeing a black patient, that they are not as smart, not as educated, not going to follow instructions, and that they'll forego the money to put the hip replacement in because they don't want to deal. And what I'm not hearing from you guys, and maybe this is a little too tough and a little too sensitive, but how policy is going to change these issues. How are you going to get hospitals and doctors to treat people the same way, even though they're already getting paid for it? How do you incentivize them or educate them that these women need this care, and historically they haven't been getting the care? There are ways to do it, but I don't see anybody doing it. And I'm going to use those two examples because they're the most powerful, and their data is everywhere in the country.
Okay. Denise?
I was going to say, and I clearly don't have the answer, and she knows that, but but I will say that part of it certainly is by having the candor and dialogue that we're having, and I think it takes to get policy there. I think that as Daniel was saying, you've got to get the research, and so part of the challenge. I can only talk about one example. What we decided in our system, and I work for Trinity Health, which is another one of the, and we're not even Detroit-based anymore because we closed our Detroit facility, so we're actually based out of Novi, Michigan now. But we did at least, I think, and I'm going to call it bravery because we decided to do an equity and care initiative, and a lot of health systems will talk about that. But our equity and care initiative is so basic, you'll laugh. We decided to train our registration staff to ask people where they identified themselves on 3 areas: religion, which is always on everybody's patient registration information, but you'll notice sometimes you have none known because we very rarely ask African Americans because they get confused. You say AME, they're like, well, it's AME, or, you know, so we said you have to ask. The second one, which you had to ask language preference, so there wasn't an assumption there. And the third that you had to ask, and this is the tricky part, where did they identify from a racial and ethnic perspective? So I think what we will do with that data, so that's the very, very early phases. We started in January. I told some folks earlier this morning, but the power behind that became because our physicians and nurses will say, Denise, oh my God, you're racist. How dare you say we treat people different in the ED? Because I do say it. Because the people come to my office and complain about how they were spoken to negatively, how they didn't get the same aspirin that the person in the next bed got, because we know we're being treated differently. And so what we did with the data is we looked at hospital readmission. So when you talk about how are you going to incent people, we will begin to lose money as hospitals for readmissions. So what we did with our utilization review staff is took our data once we started in January identifying who was who, and long story short determined that our African American patients were being readmitted at higher rates, though they were a very small proportion of the actual patients in the sample. When we dug deeper, called people and said, we sent the home health care agency there, but you never took the appointment. Or we told you to follow up with your doctor in 5 days. We see here you never went. We began to understand that how we treated those patients, how we expected them to react to the system that really wasn't built around their needs, was treating them differently and to some degree getting a different and a less optimal outcome. So I think my long answer around the policy is you have to prove to people, because it's very, we don't represent, and by we I mean this collective minority. Certainly if you pare it down to African Americans, even as physicians, as administrators, as policymakers, we represent a gnat. You go in the room and you begin to convene the conversation, and it's 2 of us with 70 people trying to say, but wait a minute, we've got to tell them that they're doing something different. So it does take courage. It takes forums like this. It takes taking this information from the CBCF and publishing it taking the risk that everything may not be evidence-based. I don't know how to give you evidence that someone looked at you in a different way or someone didn't believe your sickle cell pain was real, but I can tell you the repetitive stories that we have and the facts that we have that people abandon the traditional healthcare system because they can't get what they need to feel better has to somehow be quantified, because that's the only way you're going to move it into policy to say, I go back to my Pollyannish culturally competent care, which is the code word for saying get more of us trained and into the profession to be advocates in our communities so that we can improve the outcomes, because that really is going to be the long road to getting there.
And I actually just wanted to add to that. I thought it was a pretty good question. In health reform, one of the things that we were trying to do was to incentivize providers who would create initiatives to reduce disparities in their care. And in the health insurance exchanges, there is a provision in there, was an amendment that was brought by Senators Mikulski and Burris. And what this would do is it forces the plans. If you want to be a qualified health plan in the health insurance exchange, you have to submit a plan about how you're going to incentivize providers to create these initiatives, to address the cultural competence of their providers. And so that was one thing. The other thing is that as we move from this fee for service to this pay for performance model, and as we really look at quality and value versus volume and go down that road, when we talk about the value-based purchasing, for instance, 2% of hospitals' DRGs, so their reimbursement, is going to be tied to quality indicators. And one of the things that we're doing at Premier is to make sure that these quality measures, these indicators are diseases and conditions that are prevalent in racial and ethnic minority communities as well. So as the regulations come out, we want to make sure that that's addressed in regulations. And then the other thing too is physicians. They also will have a percentage of their reimbursement. I think it's about 2% as well, 1.5% the first year, and then it goes up to 2%. Of their reimbursement is going to be tied to quality as well. So they're going to have to look out for those issues. So it's really incentivizing, you have those carrots and sticks, and I think for the most part the bill does a pretty good job with that. And then there are also there's a great provision about patient decision aids and really making what I call this robust, informed consent model. And so hospitals and others and physicians will have to come together and develop these decision-making aids for their patients. And I think one of the things that we're focusing on, even with the accountable care organizations, which, as you know, is coming through the pike, and we're thinking about 2012, those will be coming out. What this is a model that's supposed to really look at patient-centeredness, and it's going to include not only hospitals, but providers and nursing homes, home health agencies. Together, they're going to look at the continuum of care, and they're going to have to take accountability for a defined population. And we want to make sure that as they're going through with the regulations, that they're not going to look out for the healthier and the wealthier folks in their communities, that they also have to take within their everyone in the community, poor, rich, what have you. And so in there are also incentive payments to increase quality, yes, but we're also making sure that in the regulations, they're forbidden from expanding disparities in care moving forward. So as you increase quality, you know, the concern is that they might also increase the gap. So those are things that we try to get addressed in the bill, and then we will also be doing with regulations during implementation.
I had one comment related to that, sort of on the other end of policy, and that would be healthcare advocacy and also patient empowerment and education. I think that, you know, it's great that if these changes are being made, that Dana was talking about as far as the policies and incentives are concerned on the doctor's end, because that's very important. But I also think we need to do more to educate the patients. Because they're getting these plans, they're about 50 pages long, they don't know what they actually qualify to get or not get. And you know, the statistic that you said about black women having this at a higher rate than black men, well, a lot of times the women are going to the doctors with their husbands or brothers or fathers, so they're able to advocate for them and get them the services that they need. But as Black women, who's going to the doctors with Black women? So you always need a person to go with you to be able to say, this is what my mother can get, this is what my sister can get, and so I need to find out when or how they need to do that. But if we're not aware of what we're eligible to receive as a patient, I think that that puts us in a poorer position as well. So I think that being able to do this and finding ways for policies to show that we're able to look at these plans more thoroughly, that they can incentivize the plans even by saying how many of your plan carriers have you educated about their benefits. So I think some of those things will help that as well.
Okay. Thank you. Have a question over here?
Yes. Good afternoon, everyone. My name is Chade Brown, and I am going to be the black sheep a little bit of the discussion here, given that the focus, and rightfully so in many ways, is surrounded around healthcare reform. But as an insurance consultant, a benefits consultant, I focus on the insurance side a little bit more. So with that being said, you know, my attention is tightly focused on this long overdue reform within healthcare that's being implemented now and that will be implemented down the line. And with that said, implementation is the key to my question. So there's a tremendous amount of concern. So I broker employer-sponsored plans. So there's a tremendous amount of concern within the healthcare broker/consultant industry as we embark on these changes about what our fate will be in terms of relevancy and being able to provide support to our clientele. Now, some of the main examples that concern us is medical loss ratio and how that's being defined at 85%, meaning that you have to spend 85 cents of every dollar on actual care as opposed to the administrative side, for those who may not know. And that may prohibit carriers from being able to provide compensation for us as consultants. And that along, so MLR, along with the resource sites that are being put in place to facilitate the purchasing of these plans within the exchanges, may jeopardize the support provided by groups and furthermore their employees in navigating through an overly complex industry. And I know this because I've been doing this for a very long time. So as such, can any of you speak about any safeguards within the implementation and rollout strategies to the reform that will prevent my clients, employer groups in general, and the individuals who will be purchasing from these exchanges losing the support? Because I do believe that, and I will say lastly, that I do believe that we need and we needed reform within healthcare, but I'm very much concerned about what, and that was a great segue in your comment that you just made, that healthcare advocacy and education for patients, because I largely consider myself to be that as well as a consultant. So if Mr. Dawes could speak to that, and possibly Mr. Simmons specifically. Thank you.
Absolutely. I just want to, for full disclosure, my father also is an insurance broker, and my uncle is. And it's funny because 2 nights ago, my uncle said the same thing. He says, well, we hear about these health insurance exchanges and that they're going to have this marketplace for folks to go and buy. What does this mean for my career? What am I going to do? And I said, well, that's a very good question. I said in the bill there are what we call navigators to help folks get the insurance that they need. And I said, my understanding right now, and I know these are still being fleshed out with the administration, but my understanding is that you can apply to be a navigator, you can get a grant or participate and help folks to understand where they can get insurance, how they can get it. You can also provide that for them. I know the insurance companies are working closely with Families USA and other consumer groups, and their goal is to just really help folks navigate the whole system and purchase coverage. So I didn't get a sense from Secretary Sebelius when we met with her that they were going to jeopardize that I guess the status quo as it is for insurance agents. I think that still is going to stay in place. I mean, there might be some, of course, unintended consequences as we go through the line. I just can't think of them right now, but I think for the most part, I've gotten some assurances from the Secretary and from Nancy and DeParle as we were talking through this, that they're really going to try to make sure that they stick to health insurance agents and brokers being able to provide that coverage to folks. And then when you talk about that whole commission now, I know they're thinking maybe to go from commission to maybe flat fees. That might change. So those are things that they're discussing. But I don't think insurance agents are going to be, wiped out and lose their right.
So I don't know anything about your question, but let me just I'll say more broadly, one of the things that's going to happen is there will be some fixes that occur to this bill. They're already starting to talk about some. And when I take my partisan hat off and just look at this as kind of an American experiment, there is a reason sometimes why you need to have Democrats and Republicans at the table. And one of those reasons, I was a small business owner for 3.5 years, and one of those reasons is because sometimes Democrats don't always think about the impact of this real life legislation and regulation on people who are, putting it into effect. There's a rule that people are talking about now that we're going to have to deal with that will mandate a lot of small businesses or businesses in general to have to give 1099s to people that they, pay over the course of the year. Before, you didn't have to do that for an LLC or for a company, only for individuals. And so now that will happen. You have to do that for everyone, which will just completely tie up any business owner. You're trying to find the tax ID number for the phone company. So sometimes it is helpful to have people at the table who have different ideas because they do help make better legislation. And by not having all those folks at the table at the end of the healthcare debate, I think there's some pieces of this legislation that will have to get fixed over the coming year.
Yes, in the back.
It's on. An observation and a question. The doctor at the other table was talking about how some of the cardiologists are almost like demigods in some respects. And we're talking about how changing the healthcare process such that you don't reward the procedure-based physicians as much. And people aren't into that especially necessarily just because of the money. Having gone to medical school, it's more like, it's like everyone sitting here. If I told you I was a neurosurgeon, a brain surgeon, versus a family doctor working down the street, which one would you think is more prestigious? Same thing. In medical school, people, you're going to be a brain surgeon, you're going to be a liver doctor, and so it's more, that's why people kind of go into that stuff. They like it. But here's the thing. You're going to have more, we're already at a shortage of primary care. We already have the subspecialists, orthopedist, cardiologist, orthopedist for me particularly, the biggest pains. But they're not price sensitive. You can say to them, I'll pay you 10% more money if you take call on Saturday, and they'll go, no. Okay, so what I'm trying to say is you can't make me fix anybody's hip if I'm an orthopedic surgeon, okay? So you can do anything you want with the healthcare system, put more primary care doctors out there and all that sort of stuff, but if the specialties, which you're trying to basically disincentivize, so they're going to be even more, what do you call it, just fewer and fewer subspecialists. So how do we get through that part? I mean, that's kind of an unintended consequence is what I would describe it. It's already bad. As a hospital administrator, I'm sure you already know that. So when I'm saying it, I'm not, what do you think?
Well, okay, so this is just what I think. Number one, that my physician colleagues would tell you, I love orthopedic surgeons just like I do primary care docs, so it's nothing personal. And so my reform point to it, though, you're absolutely right. The unintended consequences, I would think, when you think of the sacrifice that our medical community has made, clearly people hopefully are doing what they love. We created the economic malalignment, I think, just in terms of not, we introduced preventive care codes in our country and we assigned them with no payment. That wasn't any physician's fault. That was our health care system valuing something but not assigning any economic value to it. So I agree with you that at least what I think is that the drive to primary care is the right thing to do because you want to address the preventive health. And you do also have to accept the belief that from a public health perspective, a lot of what we deal with in disease is preventable. But it's preventable at an incredibly, someone mentioned, ever so slightly childhood obesity here. And so when you look from a generational perspective, a lot of the childhood obesity movement is to know that that generation now is being pegged to live less years than their parents, and it's because at a much earlier age they're experiencing the overweight risk factor, which will drive all the other chronic conditions as they get older. So I say all that to say, if you put the primary care in place at an early enough point in time, you're going to hopefully change the progression of disease and the onset of disease. So maybe you have some reduction at some point, and it's very longitudinal in the number of specialists that you need. But in the short term, I'm a certain advocate because the American Hospital Association and the American Medical Association, I think, has at least partnered in the perspective that we don't think there's any benefit to robbing orthopedic surgeons to pay primary care physicians, because you cannot lose anything. The shortage is across the board. So you've got to figure out how to infuse what you need. And I think part of this whole dilemma with our reform is you can essentially call it an unfunded mandate. We went forth with the perspective that we had enough money in the system, and simply by reallocating and readjusting it, that we were going to be able to add several million people to the need. And I'm not speaking as a healthcare administrator, I'm speaking as a consumer. I don't know if that's true. And so we are going to have to work through this, learning and reacting, and the policymakers that are a part of my panel certainly can speak to the modifications I think that will occur, because I think I've said in every panel I've been on this week, this is a lifetime journey. We didn't believe, at least I didn't in my professional career and in my lifetime, I'd see reform. So incredibly proud and excited that we were courageous enough to do it. But I think I also know that it'll be my whole lifetime where we will continue to reform the system and modify it and make it work. So no quick fix, and I don't think there's any easy answer.
Hi, Ebony Lewis, Associate Physician Recruiter at Kaiser Permanente. In Southern California. I traveled to all the different HBCUs to try to recruit more African American physicians, but however, when I go out and see what is there, there's not a large number in our residency programs, especially at the HBCUs. What are we doing to ensure that we have more African Americans going, not only in just becoming physicians so that we can address the cultural biases, and also to have more African Americans go into the workforce in healthcare? Are there any organizations working towards that?
I could speak on behalf of just the arena that I deal with, again, with substance abuse and mental health services. And one of the programs that we have is the Minority Fellowship Program. It's a partnership program between the Center for Substance Abuse Treatment and also the Center for Mental Health Services. So we jointly fund this initiative that really is trying to facilitate the entry of ethnic minorities into the fields, mental health fields and substance abuse fields, trying to increase the numbers of medical doctors, psychologists, psychiatrists, and so there are funds out there through the Black Nurses Program, through the other like pre-med programs at HBCUs and other majority institutions as well, and these students can get fellowships to be able to do that. And so I can provide you some more information directly about that if you're interested in finding out more about the Minority Fellows programs, activities that they do through the year so that you can find these students throughout the country and be able to recruit them. In the other arena, my other hat, which is the HBCU Center for Excellence work that we do, we try to get the students that have not decided what their majors are going to be a lot of times, freshmen and sophomores, that participate in our policy academies. Not only are they there to learn more about policy in general, how policy is made, what health policy really is as it relates to substance abuse and mental health, but also to introduce them to professionals that are in the medical field, that are in other behavioral health fields, so that they can find a way to, when they decide to matriculate into a degree program, that they would pick these fields. So those are two areas that we deal with at SAMHSA.
I think I would just add to that, the National Association of Health Services Executives certainly has a very rich program as it relates to introducing people to healthcare administration, very broadly though, not just health systems. We have some of our membership that are here today that are in public health, health department delivery that are in community health centers. So, a very broad pipeline strategy there. University of Michigan, I had to say it again, has a program called the Summer Enrichment Program, which also seeks to, I think, help undergraduate students really understand. I mean, if you go to a high school, I had a young man seek me out in the community because he said he wanted to be a hospital CEO. He's like a junior in high school. And I was like, oh, how did you figure that out? Because people don't always even know, what that is, because it's not really business. We're not really physicians. It's kind of this pseudoism. But literally, we're the captain of the ship. I mean, everybody that's a part of that work is somehow moving on our vision and our strategy. So it's a significant contribution to the healthcare delivery system, at least, but no one knows what it is. It's hard to make people kind of understand it. So we've connected. You probably have to, I think, maybe be at least an undergrad to even have a concept of what classes to take, but that's a great program. And there's also one, I think, out of the Institute of Diversity. So I can give you Nasi's contact information as well and see how we might be able to partner.
I do want to add that there are similar programs, since they're not represented here, in the American Medical Association, the National Medical Association has a program. Also in public health, there are programs to move beyond Michigan. Johns Hopkins, we have a summer program where we bring African American and Hispanic students to spend the summer with us. We had about 40 students this summer, and most of the leading universities, medical and public health schools, have similar programs. University of North Carolina has one also, and of course Michigan has one. I do want to make one comment though about the, just sort of as privileged as the moderator, I guess, that and I first want to preface my comment by saying that I'm a graduate of Historically Black College, and my son is now a student at one, but only about 35% of African Americans attend that are seeking bachelor's degrees attend historically black colleges. If we're going to do recruitment programs to find African Americans to go into the health professions, I would suggest that we need to go beyond just the historically black colleges. I'm not suggesting that we not go to them, but I'm saying that 65% of the bachelor degree student degree-seeking African Americans are not at the historically black colleges. So we certainly don't want to leave that pool of students out, because they need mentoring and they need information about what opportunities are out there for them as well. So I have a question here.
Thank you. My name is Melissa Douglas. I work with HIV Prevention Trials Network. Yesterday, I heard a lecture by Fran Phillips, who is the Deputy Secretary in Maryland, and she discussed a lot on health care reform. And I represent nurses, so I'm not sure if there's nurses in the room, but I do have a question for Denise Williams. From what you know of health care reform in the bill and everything we've discussed, we've focused a lot on physicians and health disparities. What exactly do you think would be the role of the advanced practice nurse? The nurse practitioner? I'm a community public health nurse, but it's just a wide umbrella of roles we play, and I think sometimes that gets missed in discussions about healthcare reform. Even though it's healthcare, we have physicians, nurses, and other advocates in healthcare initiatives. But what exactly do you think will be the new emerging role for the advanced practice nurse?
I definitely think that the advanced practice nurse, and in my statistics, just know I gave you nursing statistics too, but I would definitely say that you're absolutely right. I mean, I think that this answer to the primary care shortage is going to cause us, I think, to have a second generation look at all of our mid-level partnerships, and so you'll probably see more physician assistants that are coming in. You certainly are going to see more nurse practitioners, and you know better than I do that the data would suggest that from a prevention and a primary care perspective, there certainly have been evidence-based studies that would suggest that that nurse practitioner role in the community-based setting serves so many other elements of health education and health promotion, the time that you allocate to visit and the teaching that you typically get from a nursing encounter that you may not get in a physician encounter. So I think that the reform bill specifically, I guess, speaks to it, because most of the data that I brought today was really related to the racial and ethnic disparity piece. So that element from a workforce diversity certainly speaks to increasing the nursing pipeline. Daniel might know better than I what other language there may have been in there around mid-levels, but I do know that in my own work group, which is several health systems, several community health sites, that absolutely everyone knows that that relationship with nurse practitioners and physician's assistants will be critical to increasing the pipeline and in the specialty arena as well.
Okay, we've got only about 5 minutes left, and I'd like to have us give each panelist an opportunity to sum up. And specifically, I'd like to ask if you could, so we're undergoing this seismic shift in the healthcare of this country, which creates a great many opportunities. And we're here addressing the emerging leaders. Any advice you can give them about what opportunities you see that they may be able to take advantage of, whether it be career choices or business opportunities or any opportunities that you'd like to put out there? Why don't we start on the, why don't we come back the other way? We start with Shannon, why don't you? Behavioral health and.
Well, of course, because of the work that I do with HBCU students, I definitely would advocate for more students, more people that are looking for a career change, because we do have a lot of mid-career people that are coming in interested in the behavioral health field, to really take a hard and fast look at substance abuse and mental health services. Really, as the federal government and states move forward with any of the interrelated tasks in reducing disparities and reforming healthcare, it would be vitally important to monitor data on substance use and treatment, along with what's going on with racial and ethnic minorities. I think it's really important that we speak to students about this field and how important it is to actually have someone that looks like you treat you. I think that we miss that a lot of times, and we talked about relapse and readmissions in hospitals, and a lot of our people are getting their first look at treatment in emergency rooms, and that's not where people need to go for treatment and services. So I would definitely go out there. I think Dr. Levis made a very good point about looking at the majority institutions as well. I went to a majority institution, and a lot of times we didn't hear from any of the groups that really were trying to recruit African Americans, because they did go to the HBCUs. But I think any time that you could put your hand on an African American student, anywhere they may be trying to further their education, that I would definitely push the importance of the behavioral health field. So I just thank you for this opportunity to be on the panel, and I'll be here to answer any questions afterwards.
Okay, thank you.
Thank you. It's funny, I don't remember, I spent 2 years in policy school, and two subjects that were always hard for me were economics and statistics. But the one thing I remember about statistics in particular is that you've got to disaggregate the data. You've always got to, you can't look at the total numbers when you're paying attention to what's happening, and I've always used that in my policy, my political work, is pulling that apart and looking at it. And the thing I remember from economics is a rising tide does not lift all boats. So you've got to, the data will tell you where you need to focus if you pull it apart and take a look at it, and then you've got to make sure you put policies in place that address the concerns that you see and make sure that people actually who need the help and the work are getting that. One of the ways that happens in a policy discussion is to have people who come from communities sitting at the table where those discussions are taking place. And what I see here in Washington very often is the way that we funnel people through this process to end up in many of the leadership positions is it starts very early. It starts at 18, 19, 20, 21 years old when people are students and they're coming here to do internships. And very often what happens in the Congressional Black Caucus, should be commended for taking this on, and in your local communities I would advise people to try to take this on, is when I was in school, I couldn't afford to work anywhere for free. Because I was hustling every semester, every summer to try to pay for, the last bill that was late, so I could go to so I could stay in class just so I could get the degree to do the next one. So we need actually to find a way to have our kids be able to do a lot of these internships and come to places like Washington where they can live, at least have a place to live and a little money in their pocket, so they don't have to, work at night at a restaurant or at a McDonald's while they're on Capitol Hill during the day or at some other institute. So if you find ways to be able to support students while they're pursuing their dreams, unlike some of our peers who get a little bit more family support and can afford it. And the last thing I'd say is for those people who are concerned about reform, we live in this great era And I'm going to apologize for having walked out a few minutes earlier. I will let you all in on something. I am going to a new network, and that was my lawyer that was calling me on the phone while we were finishing my contract. So I needed to deal with that. But one of the things that's happening in this new media is that there's a lot of opportunities for people to tell their own stories and to get out there. And you don't need to have, 20 years ago, if you had a story to tell or you wanted something to be in the public sphere, you had to go to a bunch of people sitting in New York or Washington, editors, supervising producers, who would then decide whether or not your story was important enough. You can now tell your story on your own, on the internet, and get other stories out there that you think are important. One of the big fights in healthcare reform is going to be to find people, real live human beings who have benefited from the changes that are being made to combat some of the scare tactics that you'll hear from the other side. So as you find those people, encourage them, do yourself, write letters, write blogs, put videos up on YouTube, use your websites, get them to your members of Congress so that they know they exist in their communities, so that we aren't put in the same position 2 years from now where people are showing up at town hall meetings, screaming and chanting and yelling and waving signs while our people stand there and look silly because they don't have anything to say. We need their allies to show up and chant and make signs and do stuff and say, I am a person who benefited from this. You keep doing what you're doing. And that's going to stiffen their spines. So with that, I want to thank you all for having me. It was a pleasure to be here.
The panel allowed for me to reflect on a lot of spaces that I've been in personally. I know we've heard a lot about Michigan today, but I went to Ohio University, which is in Athens, Ohio. And one of the good things about Ohio University is that it's the home of the Ohio University College of, I believe it's osteopathic medicine. And when I was there, they had an African-American woman as a dean, Dean Ross. And so they did an incredible job of recruiting students from, ironically, HBCU campuses to come over the summer to just immerse themselves in the summer and participate on campus life and move forward into getting into the program. But as I've had an HBCU experience as well, and now I work predominantly within the African American community through the faith institution, I'm learning that the way of going forward is to have those conversations. And again, having environments where people feel safe. It's similar as I hear medical professionals share how they build their relationships with their patients, or I don't think they refer to them as clients, but I think they're patients, and the type of manner that they have to have and care for them. And so when we can have space where we can allow people to ask the questions that they need to, and more importantly, inform them with the information that they need to be able to make healthy decisions, I think that's important. And then lastly, two other areas that I'm in. Right here, I do a doctorate of ministry through Wesley Theological Seminary, and our campus is actually in Mount Vernon Square, pointing because it's right next to the church that sits right outside and that new structure that's there. And the reason that they started that program was to really deal with issues of urban ministry. And this cohort or this group started at the beginning of this year. And these are the very issues that we're discussing. But we know that there's a need to be in relationship with the experts and share that expertise, because there's an emerging leadership within the faith community that some people may not believe it or not, but the pastor does not have all the answers. And I'm the first to say I don't serve as a pastor presently, but I know that pastors and pastoral leadership do not have all the answers. But the good news is that they're in relationship with people that do have the answers, and many of them are in the pews, many of them are in the local community. And I know one thing that a pastor can do is use their influence to be able to galvanize, to have these local and needed conversations. Lastly, another group that has formed, I'm in the Atlanta area, is that there is a conversation between all across socioeconomic areas, but more inclusive of there's ministers that come from a politically left background as well as a politically right background, and we've come together to talk about just the needs at the local community level. The policy is there, and we have to learn how to navigate it, but the goal, again, I'll just reiterate, is that how do we allow for this to reach the people where they are, where it actually is of benefit.
Okay, thank you.
Thank you. So we've heard about the hurdles that we had to go through to get the health equity provisions and health reform and to keep them intact throughout the whole negotiation process. And as we move forward, if you're like me, I know we're tired, but now is not the time to rest because there are so many folks, so many opponents right now who are just waiting for that moment when we're not aware to strip out many of those provisions or to water them down during the implementation process. And so there are a couple things that I wanted to bring to your attention. One is the adequate funding issue. Many of the provisions in health reform around workforce, prevention, quality, a lot of them were discretionary funding. So the programs were authorized, but they were not appropriated any funds. Few of them have mandatory funding in there. And so we're going to have to fight to get appropriators to allocate some dollars to those programs. In the same vein, we're going to also have to make sure that those programs that do have mandatory funding, that there aren't any attempts to repeal, to defund any of those provisions, because, and this was raised earlier today at the CBC Health Brain Trust, Senator Johans, many of you might have heard his name on the TV recently. He had basically, and I know Jamal just mentioned the 1099 issue with small businesses, but what he tried to do was to introduce an amendment in there that would basically strip out $11 billion of the $15 billion in mandatory funding that the Public Health Fund had received. And that was a critical fund because the community transformation grants, which you might have heard about, will be getting some of the monies from that public health fund so that community-based organizations, hospitals, and others can come together and develop these initiatives to reduce disparities. And if that fund had been wiped out, guess what? A critical source of funding for these initiatives would have been wiped out. So as we're going forward, keep the funding issue in place. And the other thing too is, God forbid the House does flip, then our chances are even going to be more difficult that we'd get even any of the funding. So November 2nd, remember that as well. Then the other thing is that I've heard today many of you talk about your areas of expertise, and we've heard folks saying you need to be at the table. And I think that as we're moving forward, it's critical that you provide letters of comment to the regulators, that you provide yourselves as a source of knowledge and expertise to them as they're writing the regulations on many of these provisions. The other thing is that there are key advisory groups, commissions and committees that will be created or have been created in the law, and there are many opportunities for all of us to participate on them or to nominate folks who can represent us on these key committees and boards. Another thing is the national strategies that will be created. You have a national strategy on quality improvement, another one on prevention, and some others. And I think it's very key that our voices are heard within those national strategies as well, because a key component of those strategies was to reduce disparities. And I'm afraid that if our voices aren't loud enough and if our message isn't clear enough, folks are going to lose that going forward. And then lastly, we have to keep a watchful eye on efforts to amend or to repeal this. You know, we keep talking about this, and I've actually had the opportunity, I've spoken in Nebraska and some other rural areas to very conservative audiences, and you know, many folks keep attacking as Obamacare, and they're very diligent in their efforts, and they are very unrelenting. And so I think moving forward, we just need to make sure that we're keeping a watchful eye with any of the amendments in Congress, with any Republican attempts and even Democratic attempts. I know, we're talking about messaging, and I just read a statistic that opponents are spending 7-to-1 on attack ads for this. Mm-hmm. And even some Democrats now conservative Dems are going over and even blasting the health reform law. So I just think it's important for us to keep that in mind going forward and just be watchful. So I'll just end here and thank you very much as well.
Okay, so there's not much left to say. That's what I get for being last, right? Well, what I would say is if you really think back to how we started our conversation, the politics and healthcare, I'm going to actually leave you with a thought that would suggest it's not political. Health disparities, health inequities do exist. And so I think the unique mandate that we have is to not forget that, because it's not about ultimately the policy or the dollars that come into the system or don't come into the system. It's that we're losing years and losing people at a disproportionate rate. And so whatever mobilization that causes you to have, I think on all the areas that we describe from a technical perspective around the reform bill, don't forget that it really is related to the fact that African Americans in particular lead the statistics in a negative way in almost any health indicator that you look at. So premature deaths, not getting, you heard Dr. Arsenberry talk about not getting access to the right things even though they have access to care, having diseases that are highly preventable, but perhaps not having the support or having the social determinant of stress or lack of access that, can't help to abate that. So I think that what we have to remember is that reform is a catalyst, it's a dialogue, it's a conversation, but the political misstep would be for us to think that's all it is. And not be strong advocates and proponents. And that takes courage, because each one of us in our, highly professional business suit day job could become afraid to go to the table and say substance abuse, mental health isn't something that people get that are African American. I could, become afraid to be a delivery advocate, a policy advocate, so on and so forth, because we're empowered as a result sometimes of the roles that we play in our professional life. But if we do not stay courageous and push and be strong proponents in the face of what will be tremendous adversary, and a lot of that adversary has become very ugly because of, I believe, the fear that the actual inequities and disparities are going to be closed. And so being able to be honest about that, being able to push through that, and my one little note that I wrote to myself is we talked about the American Hospital Association, the American Medical Association, then we talked about the NMA and the National Association of Health Services Executives. There's a National Bar Association, but there's American Bar Association. So I always laugh, and I'm like, the commitment I give to you as emerging leaders, because I get this question as the president of a minority healthcare organization. Well, why do that when I'm in the American, College of Healthcare Executives? So really my last thought would be, because it's your responsibility, belong to both. If you can't make a choice, because if you had to make a choice, I'd tell you the choice to make. But if you can't make a choice, and your organization and your company doesn't support you being in that national forum and that national conversation or coming to the CBC, it's your responsibility as an emerging leader to not get confused that whatever struggle occurred for you to have the opportunity to be here, having this conversation will be lost if you forget that. So I think it is be advocates and be proponents of what needs to be done.
Thank you. I just want to thank the panelists and thank the audience for making this a stimulating session. We're completely out of time. And someone is telling, please fill out the evaluations, the yellow sheets of paper that you received.